So, what is the difference between the sleeve and the bypass? And I really want you to know this. Um, Similar weight loss as far as the effect on diabetes and resolution of diabetes, resolution of hypertension, very similar. The bypass has a long track record for that, but they are very similar and studies have shown that. The main points I want to get across is who would want a sleeve, who would want a bypass. If someone has real bad heartburn, then they probably should opt for the gastric bypass. If someone has bad asthma or rheumatoid arthritis or medicines that require steroids, probably should go for the sleeve. And there's a lot of other factors we can talk about in the office that point you one way or the other. The main concern with the bypass is if you smoke, if you take steroids, if you take NSAIDs like Advil, Aleve, those medications, it can give you what's called a marginal ulcer, which is an ulcer right here on the small bowel, just downstream from the pouch. Whereas sleeves, very rare to get an ulcer in a sleeve. Sleeves almost don't get ulcers, so that's one difference. Ulcers. Bowel obstruction is another issue. After any surgery, appendectomy, gallbladder, you're at risk for bowel obstruction. Usually it's due to adhesions in the abdomen. It can happen many years later. However, with the bypass, there's an increased risk of bowel obstructions, mainly due to the way we have to reroute the intestines. Maybe 5 to 10% lifetime risk, whereas the risk for other surgeries is much lower than that, maybe on 1%, less than 1%. So that's something to consider. And the third issue, the difference between a sleeve and the bypass, is access to the remnant. This is the remnant, okay? So why would we need to access it? Well, say we do your bypass, you're 20 years old, and you take your vitamins, you do everything right, and your labs are fine every year, and now you're 50 years old and suddenly you're anemic. Well, generally the first thing we would do is do a colonoscopy to make sure you don't have a colon tumor, and do an upper scope, make sure you don't have an ulcer, that you're losing blood. The problem is we can't scope and get to this remnant to look at that. So there are other ways we can look at that, but they're just not as good as endoscopy. So access to the remnant is an issue with the bypass. But generally it's not a huge problem, but just something I want to educate the patients on.